1 month after the onset of abdominal distension. There is no history of decrease in urine output preceding or simultaneous to the onset of abdominal distension, and there is no history of breathlessness or swelling around the eyes during the same time. This patient came to the hospital with 2-day history of black colored stools prior to his admission, and he noticed black colored foul smelling tarry stools, which was associated with dizziness and palpitations. There is no history of blood and vomiting, no history of abdominal pain. There is no history of loss of consciousness during or after the episode. There is no history of bleeding from any other side of the body. Patient was admitted with aforementioned complaints, and upon admission, 2 units of blood were transfused and he underwent an endoscopic procedure and bands were applied. Later on the same day, patient relative noticed gradual onset progressive irrelevant talks and restlessness. It was not associated with any inability to move any part of body or tremors or hallucinations. There is no prior history of any such previous episode, no history of change in sleep patterns, but he was kept in the ICU and improved within 2 days after treatment. There is no history of weight loss or change of appetite. There is history of tattooing over right forearm approximately 20 years ago. There is no history of prolonged drug or complementary or Ayurvedic medicine intake, but there is history of significant alcohol intake, that is approximately 100 grams per day for the last 20 years. Last alcohol intake was 1 day prior to admission. There has been no history of attempts at de-addiction, and Cage questionnaire was positive 4 out of 4. Coming to past history, so patient gives history of an episode of blood and vomiting in 2018, which required hospitalization and 2 units of blood were transfused. And an endoscopic procedure was done, the details of which are unavailable. Patient was discharged after 7 days, but without any long-term medications for the same. There is no history of any other hepatic decompensation during that episode. There is no history of diabetes mellitus, hypertension, tuberculosis, coronary artery disease, or cerebrovascular disease. Personal history. Patient takes a mixed diet, that is both vegetarian, non-vegetarian, and around 2500 kilocalories per day. There is no change in appetite for the duration of illness. Patient is also a chronic smoker and smokes about 1 to 2 cigarettes per day for the last 30 years. I've described the alcohol history previously. There is no significant treatment history except the part that was in past history when he had upper GI bleed. Family history is not significant. There is no history of any liver-related ailment in the family. Now coming to summary of history. So 48-year-old male patient with alcohol use disorder presented with painless progressive jaundice without prodrome associated with ascites and a history of melena followed by development of altered sensorium. So my first differential diagnosis would be cirrhosis with acute decompensation with upper GI bleed with ascites and altered sensorium, which could either be encephalopathy or be alcohol withdrawal. My second differential diagnosis is severe alcoholic hepatitis with ascites, upper GI bleed, and alcohol withdrawal. And third is acute and chronic liver failure.
Okay, so I think the history is fairly clear in this situation. The main differential then comes in how do you separate these things out, whether it is alcohol withdrawal or not. So what are the features that you were pointing towards alcohol withdrawal or the absence of alcohol withdrawal? Second question is, what are the other possible causes in this situation which could be resulting in altered sensorium besides the encephalopathy and alcohol withdrawal?
So, sir, in alcohol withdrawal, patient usually has more agitated behavior. There are tremors are more generalized tremors are more common in alcohol withdrawal, and there is a history of antecedent alcohol intake within the last 24 to 48 hours. And in hepatic encephalopathy, usually, sir, a precipitant is present that can trigger hepatic encephalopathy. The hepatic encephalopathy patient is usually hypoactive rather than agitated as compared to alcohol withdrawal. And second, asterixis are present in hepatic encephalopathy, which are not present in alcohol withdrawal. And so that's it. That all. And sir, other features that may be complicating it, based on the clinical history, patient might have underlying cirrhosis, and in such patients, sir, hyponatremia can also occur, which can also present like this with altered sensorium.
So one of the major things that always remember is sepsis and infection, which sometimes will also cause breath problems. Secondly, in alcoholics, again, you can't always rule out any subdural hematoma and other possibilities which may be causing altered sensorium. Although in his case, since the sensorium improved after 2 days of ICU as per your history, so the chances of that are relatively low. But those are things to be kept in mind. The second question is, you said severe alcoholic hepatitis with ascites. So what are the features that would tell you this is alcoholic hepatitis in this situation?
Sir, the diagnosis of alcoholic hepatitis is based on first the history of alcohol intake and mainly on laboratory features. Apart from history, so it is very difficult to differentiate based on history. But based on laboratory features and AST-LT ratio more than 1.5, bilirubin more than 3, and an history of alcohol intake within the last 60 days, significant alcohol intake within the last 60 days.
Right. And the other feature sometimes with alcoholic hepatitis is if there's pain and tenderness over the liver. So that is something that one can associate clinically if there's pain and tenderness over the liver. And besides the laboratory features and the rate at which the bilirubin has gone up or down. So depending on duration also. And then the third point that you have raised is acute and chronic liver failure. So again, what are the features that will tell you this is chronic liver disease just worsened with encephalopathy following GI bleed, whether it is acute and chronic liver failure? Just basic clinical, I know there are multiple criteria.
Yes, sir. Since there are multiple criteria and most of them use organ failure as a criteria to define ACLF. So I have kept it as the last because since I don't have lab values available at this moment in history taking, so I have kept it the last possibility. And however, there is no stigmata of any organ failure till now in the history.
So there's one question from the panel, also from the audience also. In a cirrhotic patient, is it appropriate to justifiable to say there's no decrease in urine output? So in a cirrhotic patient with ascites, is it justifiable to say no decrease in urine output?
Yes, sir. Patient can still have ascites in the absence of decrease in urine output, and so one of it predisposes, and but however it is not necessary. And
so I think I'll answer that question. That you may not have decrease in urine output at all. You may have ascites without decrease in urine output. If there is associated decrease in urine output along with ascites, then you think more in terms of patients going into oliguric renal failure, pre-renal syndrome, or even HRS. So I think that you can have ascites with good urine output. You can have ascites with decreased urine output. All right. So let's, Dr. Vikas, do you have any questions at this point? I think he's not on right now. Anyway, so let's proceed with what are the investigations you had.
I'll first proceed to examination, sir.
Examination, sorry. Yeah.
So on general examination, at present patient was, at time of examination, patient was conscious, alert, obeying commands and oriented to time, place and person. He was afebrile, pulse was 67 per minute, regular, rhythmic and all peripheral pulses palpable. BP was 100 by 76 millimeters in right arm supine position. Respiratory rate was 20 per minute, thoraco-abdominal. Height is 168 centimeters and weight is 98 kilograms. BMI was 34.7 kilogram per square meter. However, since patient has pedal edema and in examination I also found out ascites, I have adjusted the weight as per the Mendenhall formula of 1992 and the dry BMI is 30.8 kilogram per square meters. So on general examination, pallor is present, icterus is present, there is bilaterally symmetrical, non-tender, pitting pedal edema, present till calves. There is no cyanosis or lymphadenopathy. There is a tattoo on right forearm and there is IV cannula in right forearm. Coming to stigmata of chronic liver disease, so parotid swelling is present, palmar erythema is present, Loss of axillary and pubic hair is present. There is no gynecomastia, no testicular atrophy, spironevi, dupuytrenal contracture, hysterexis, or feeder hepaticus. Coming to abdominal examination, on inspection, the abdomen is distended. The distension is symmetrical and all quadrants move symmetrically with respiration. There is no scar, sinus, or dilated vein. The umbilicus is everted and central. Hernial sites appear intact. On palpation, the findings of inspection are confirmed. The hernial orifices are intact and there is no divarication of recti. Spleen is palpable, 3 centimeters below the costal margin, non-tender, and it is difficult to comment on the surface or other features of the spleen due to free fluid in the abdomen. Liver span cannot be assessed due to ascites, and upper border is in 5th intercostal space in mid-clavicular line.
So if you're not able to palpate the liver, how are you able to palpate the spleen?
Sir, actually the lower border of liver is not palpable, and I could only feel the upper border on percussion actually, sir. So I have mentioned it in palpation just because you mentioned liver span and percussion.
So was there a dipping palpation? Because that's the one thing that you can use in the setting of ascites.
Yes, sir, I tried it, but I could not feel it.
Okay.
Now, on percussion, so shifting dullness is present. On auscultation, vowel sounds are normal. There is no bruit or hum heard. On PR examination, the external examination is normal, anal tone is normal, and finger is smeared with yellow stool. The other systemic examination was normal. Now coming to summary, so my patient is a 48-year-old male with alcohol use disorder who presented with progressive jaundice without prodrome associated with ascites and melena, with history of altered sensorium, with presence of stigmata of chronic liver disease and portal hypertension in the form of ascites, splenomegaly, and variceal GI bleeds.
Right. So I am glad you use the term alcohol use disorder. And for the trainees, I think it's important to remember that the term alcoholic is being used very loosely, at least in the current Indian setting. And the term has been now universally replaced by alcohol use disorder, which can be of varying degrees. So I think it's important to make sure that we use the right terminology. So now, basically, at the end of the examination, what's your differential narrowed down to?
So my differential diagnosis, the first is cirrhosis of liver with acute decompensation and portal hypertension with altered sensorium. I'm not sure about the etiology of cirrhosis. It could either be alcohol. It could either be chronic viral hepatitis because patient has a history of tattooing, and patient also has a high BMI, so it could also be NAFLD along with either alcohol or viral hepatitis causing his underlying cirrhosis. My second differential is acute and chronic liver failure, and third is severe alcoholic hepatitis. I have placed alcoholic hepatitis at the third point because before history I did not have stigmata of chronic liver disease, but now since I have stigmata of chronic liver disease, I have changed the positioning of my priority.
Okay, so I think let's move on to investigations because we want to leave some time for discussion at the end from the audience. So what investigations did you have? Okay.
So sir, we went with hematological investigation, and so these are the labs, sir. I have divided day 1, day 3, day 8 and day 11. So sir, CBC at the day of admission his hemoglobin was 6.3 with an MCV of 105.8. TLC was 11.8, platelets were 135, urea was 63 milligrams per DL, creatinine was 0.73 milligrams per DL, sodium was 122, potassium was 3.6, and calcium was 8.2. On day 3, after PRBC transfusion, his hemoglobin improved to 7.5 and patient was started on antibiotics on the day of admission. On day 3, his TLC was 11, marginally improved, and gradually improved to 6.1 on day 8. On day 8, day 7, he was also again given 1 unit of PRBC, after which his hemoglobin was 8.9. He was discharged on day 12, so at day 11, his hemoglobin was around 9.5.
So basically, the hemoglobin improved after varicose band ligation and transfusion. There was no further bleeding.
Yes.
Now, one major finding in this case is the hyponatremia, sodium 122. So what's the mechanism for that, and how would you manage that, and why is it so relevant in this particular case to correct that?
So the mechanism of hyponatremia in patients with cirrhosis is because of portal hypertension that causes activation of renin-angiotensin-aldosterone system, which causes retention of water and eventually leading to dilutional hyponatremia. And
Hmm.
yes, sir.
Why is it important to correct that, and how do you correct that?
So first of all, he presented with altered sensorium, so that could have contributed to his altered sensorium. So we could improve his sensorium with that. First is that. Second is that hyponatremia is a predictor of mortality in patients with chronic liver disease, and there is increase in mortality in patients who continue to have hyponatremia. And
so one thing that happens is intracranial hypertension or ICH is increased in the setting of hyponatremia, and correcting the sodium actually decreases the chance of cerebral edema as a result of that. So I think sodium correction does become fairly vital, especially in the setting of altered sensorium in these particular cases. And how do you correct the sodium?
so first is a restriction of fluid intake.
No, but at this point, you don't know whether this is hypovolemic, whether he's,
So
low
we assess urine spot sodium. We take history of whether he was compliant with the whether there was any salt restriction present prior to this admission. Although it is unlikely since he has come with it the first time. Second is whether he was on any drugs that could have precipitated hyponatremia. And third is that if it is purely cirrhosis related, it is because of so we need to check urine spot sodium and other etiologies which might contribute to hyponatremia. And
yeah, go ahead. Yeah.
yes, so spot sodium may guide us whether if he is passing excess of salts in his urine or whether there is reduced salt excretion in the urine, and that may guide us whether he is actually salt deprived or it is just dilutional hyponatremia, and then we can guide out.
So in this particular case, there are some pointers saying that the creatinine is normal, although urea is slightly elevated, which may be from GI bleed. So it's less likely that it is a pre-renal syndrome type thing, although it is possible. The second thing is that these patients have to be managed in ICU. So yes, you look at the CVP, you look at the other parameters to assess whether the patient is hypovolemic or euvolemic or hypervolemic, and then based on that, you have to use your corrective measures for the point of view of sodium. And the threshold for using hypertonic saline is much lower in these situations because you can actually help improve the cerebral edema by correct at utilization of hypertonic saline where indicated. And I think sodium 122 is not quite as low, but there are times you get patients with sodium 110, 112, 114. And in those cases, you may want to use hypertonic saline relatively early. Okay.
So I think what's your interpretation of raised MCV and the TLC? What can be the cause of raised TLC here in this case?
So it could be an underlying infection, and patients who have that is first. Second is the patients who also have alcoholic hepatitis can have high TLC. Sir.
Yes.
Yes, sir.
And maybe the reactionary response to the bleed
yes,
also.
Sir. Yes, sir. Because of GI bleed. MCV is high, so because it can be because of two reasons. Maybe because of nutritional reasons, and maybe because of direct effect of alcohol on the folate metabolism that causes macrocytosis.
Okay. Yeah, go ahead for the investigations.
So now coming to Lfts. So at the time of admission, sir, he had severe hypoalbuminemia with albumin of 1.8. The bilirubin at admission was 11, most of which was direct, which is 6.5 milligrams per dl. His AST was 63 and ALT was 16. ALP was 125. GGT was 240 international units and INR was 2.9. His ammonia at admission was 149, which improved on day 8 to 72. However, his bilirubin continued to increase, which increased from 8.1 at the day of admission to 11 at day 3, and then going to 13.5 till day 8. Slight lowering at just prior to discharge. AST ALT, however, remained same. and albumin improved with treatment to 2.5.
So was he given albumin transfusion?
Yes, sir. He was given albumin because of severe hypoalbuminemia and ascites.
So now, are there any further investigations, or this is all the investigations you have?
So there is one other slide.
Okay, let's look at that.
So ABG at admission was pH was 7.4, PCO2 was 39, PO2 was 89, and SPO2 was 96. Bicarb was 22 and lactate was 1. Blood and urine cultures were sterile, and viral markers were negative. Hepatitis B and hepatitis C. Ascitic fluid showed a SAG of 1.5, proteins 1.8, and cells of 48, of which 80% were lymphocytes. There were no malignant cells, and ADA was 4. USG whole abdomen showed features of chronic liver disease with dilated portal vein 13 mm, moderate ascites, splenomegaly of 15 centimeters, multiple perigastric collaterals were seen. There were no hepatic mass lesion was seen, and Doppler of hepatic vessels and splenoportal axis normal. 2 ml of grade 2 columns of grade 1 and 2 columns of grade 2 varices without any high risk signs, and a large gastric fundal varix with stigmata of recent bleeding. 2 ml glue was injected and mild PHG was also present. On a CT, there was cirrhosis of liver with portal hypertension, splenomegaly and ascites, no mass lesion, no evidence of portal vein thrombosis, and multiple perigastric collaterals with gastric varix was seen.
Let's go back to your previous slide where the lab data is.
Yes.
So now that you have all the lab data and all the investigations, so what's your diagnosis now, and then the management protocols that you would follow?
So my first diagnosis would be cirrhosis of liver with acute decompensation with ascites, GI bleed, and splenomegaly with hepatic encephalopathy.
What about alcoholic hepatitis in this situation, or whether you classify this as acute and chronic liver failure at this point?
Sir, according to both all the definitions that are available, I can put him into ACLF also as per the EASL definition. However, it doesn't qualify for the APASL definition. There are, for the EASL definition also, for single organ kidney failure, at least kidney failure should be present, but which is not present in this case, so he falls out of that also. I also considered alcoholic hepatitis as a RED, but since there are features of chronic liver disease present, I excluded that.
So when do you say alcoholic hepatitis in that case? So patients, many of these patients will have history of alcohol use, will have cirrhosis, and that's why alcoholic hepatitis typically develops when you have a pre-existing chronic liver disease, and on top of that, you get alcohol.
Yes, sir, but features of portal hypertension are also present, so that goes more in sync with cirrhosis.
The basic thing is that with alcoholic hepatitis on top of chronic liver disease, if you have a rapid rise in bilirubin of more than 4 over a period of 3 to 4 weeks, and I don't remember the exact weeks criteria, if there's a rapid rise in bilirubin, if there is AST, ALT elevation and AST ratio more than 1.5, which you already pointed out, if there's elevated TLC. Now, in his case, the TLC is not very high, but TLC is slightly high. So we cannot say it for sure that this is not alcoholic hepatitis, and the bilirubin is rapidly rising afterwards also. So I think, and as this is all a spectrum in general, and alcoholic hepatitis is just one of the precipitating causes for liver failure in a patient with chronic liver disease also. So yes, one has to consider the diagnosis of alcoholic hepatitis, which has precipitated this current event. And the main current event, obviously, that has precipitated the immediate encephalopathy is the GI bleed. So I think that's the other thing that you can see. Once the GI bleed was controlled, what happened to his lab parameters, and the bilirubin kept rising despite the GI bleed having been controlled and everything else. So I think that background is important. The reason it does become important is how you treat this patient from now on.
Yeah. So Pratyush, you mentioned the patient has acute decompensation of chronic liver disease. Then you should mention what's the etiology for the chronic and acute separately, whether it's the same factor or the different factor. So you mentioned.
I think for chronic liver disease, I have my first etiology is probably alcohol. which has led to both underlying cirrhosis and acute decompensation. It might have been precipitated or worsened by an upper GI bleed, sir.
Yeah. So any other contributory factor in the form of obesity, diabetes in this patient?
The patient also has history of tattooing, so he might have viral hepatitis, but his viral markers are negative.
Okay.
But he also has, he is obese, his BMI is 30, 31, so that might also contribute.
And the blood sugar are controlled?
Yes, sir, he was non-diabetic.
So I think we should mention in the etiology that patient is likely having the alcoholic liver disease. Along with that, obesity may be a contributory factor in this case.
And the coexistence of NASH and alcoholic liver disease makes the prognosis significantly worse. So in a patient where the mortality rate may be otherwise from alcoholic cirrhosis, whatever, maybe 50%, goes up by at least 10 to 15% in patients who have associated NASH. So I think a combined diagnosis would definitely make the prognosis worse in this situation. Any questions from the audience? Would like to have some audience questions. And so now, how would you manage this patient? You have suddenly got this patient, he's come to the ER, you have to work him through quickly and go over. So you have to have a plan of management.
So my first plan of management, since he's come with a history of black stools, would be assess for a GI bleed and hemodynamic stabilization. That is one. ICU admission, that is two. Three is transfusion of blood products as required based on lab values. Four is identification of any other complications that may be happening because of an upper GI bleed. And fifth is, since he has history of alcohol intake just prior to the day of admission, so management of alcohol withdrawal along with that. And
how would you do that? So how would you manage the alcohol withdrawal?
The alcohol, so benzodiazepines are the mainstay of therapy for alcohol withdrawal. So we can either use lorazepam or chlordiazepam oxide. Both have long duration of action and are effective at treating the peripheral signs of alcohol withdrawal.
And what dosage do you use?
Lorazepam is started at 1 mg and then twice daily or thrice daily and then progressively increased depending upon the symptoms. And chlordiazepam oxide is started at dose of 25 mg thrice daily and can be assessed upon the clinical response.
Right. So one thing is that alcohol withdrawal, and once you see alcohol withdrawal, you remember it forever. And it is a major cause of morbidity and mortality. And you have to start fairly high dose of benzodiazepines. Now, the one question that always comes in, that might worsen your encephalopathy and may worsen your consciousness level. So one has to be very careful. That's the reason we have to monitor it in the ICU setting and see if the altered sensorium, and you have to be reasonably clear with if you're managing alcohol withdrawal, not as a blind thing, but yes, you have to do that. Okay, so alcohol withdrawal is one. And the second question is that his INR when he came in was 2.9, then he has had a GI bleed. Are you going to wait for the FFP before you do endoscopy? Are you going to do emergent endoscopy after blood transfusion? What are the guidelines for that?
Sir, I'd like to do emergent endoscopy to control the bleeding, sir.
Right.
And
so Pratyush,
so basically, in these situations, what you don't want to do is wait for, you have to transfuse to hemodynamically stabilize the patient as much as possible, but scope whatever the INR, because the INR number one doesn't necessarily reflect the actual coagulation situation in these cases. And second thing is the correction of INR requires high volume, fairly larger volume again of fresh frozen plasma, which can increase the colloidal pressure and decrease. And secondly, that delays the active intervention. So you essentially arrange for FFP, but don't wait for the INR correction before you do an endoscopy. So endoscopic therapy takes precedence.
So Pratyush, tell me one thing. The patient has come in the night around 2 a.m. Okay, and patient is hemodynamically stable, and you have placed a RILES 2, which is showing the altered blood. So will you go for the urgent endoscopy, or you will postpone it till the next morning?
if he is hemodynamically stable and there is no fresh blood, we can postpone it, sir. There is no need for emergent endoscopy because we don't have any evidence of active bleeding at that. But I would also, yes, sir.
Yeah. So the outcome of emergent endoscopy may not be as good as the routine endoscopy. You have limited resources for the when you do the emergency endoscopy. On the other hand, the patient is hemodynamically unstable and relative lavage showing the fresh blood. You may have to do the urgent endoscopy. Like in this patient, he had the active bleeding from the fundal varix. So the patient is candidate for the urgent endoscopy.
Now, the other question that then comes in also is that now you have a patient who we suspect may have alcohol hepatitis, which has precipitated his liver failure, is going into acute and chronic liver failure. What is the role of steroids? When would you consider using it or not consider using it? Because that becomes a very vital question in these cases.
Sir, in patients with underlying cirrhosis, there is very conflicting data regarding the use of steroids. So unless we have a clear-cut definition of severe alcoholic hepatitis with absence of underlying cirrhosis or any risk factors that preclude the use of steroids, we can use steroids, otherwise we should not. So if this patient, for example, had renal failure along with it, it would be a contraindication to use of steroids. However, in this patient, sir, I'm not sure, but based on cirrhosis, I would not like to use steroids in this patient.
So many of the patients who do present with acute alcoholic hepatitis are actually have underlying chronic liver disease. So it's very rarely that you will find somebody with without chronic liver disease and presenting with that.
And so this patient also has GI bleed, which is the contraindication.
So, Prithvi, is the cirrhosis contraindication for the steroids in alcoholic hepatitis?
No, sir, there is no contraindication, but actually it does not change overall mortality. There is no benefit in patients with.
Is there any study showing that alcoholic hepatitis with cirrhosis vis-a-vis without cirrhosis, it has a better outcome?
I'm not.
So I don't think if you have controlled the bleed in this patient, there is no sepsis, there is no AKI, and the patient having persistent high bilirubin, high SGOT-PT, there may be a role of giving the steroid, maybe for the 7 days, then calculate the Lilly score. If not favorable, sending the patient for the liver transplantation.
I think that's what you need to consider, as Dr. Vikas has rightly pointed out, that the presence of cirrhosis is not a contraindication. Many of these patients are cirrhotics. So you basically assess, make sure there's no evidence of infection and sepsis. So that will take you 48 hours to 72 hours to get cultures negative. Because many of these patients have coexistent infection and sepsis. That's number one. Second thing, if there is encephalopathy, if there's other things, then obviously you know the patient is sick and patient will require some intervention. And as long as you ruled out infection and sepsis and there is no major contraindication to steroids, that's when you can consider it. And the other thing you need to know is about Lilly score. Yes, so at day 7 is when you use Lilly score, not the MELD score, not the CPT score, to see whether the patient should continue the steroids or should come off the steroids at that point. And during this whole duration, also one has to see what is the overall clinical improvement with steroids. And at day 7, if there's not much improvement happening, then again you may be able to take the patient off steroids rather than prolonging. Suppose the patient is improving and you have started steroids and the Lilly score is favorable, then how long do you continue the steroids?
For 4 weeks, sir, at 1 mg per kg per day, and then taper off over the next 2 to 4 weeks.
I think one thing we missed, I think, is the nutrition. Nutrition plays a very crucial role in the management of alcoholic hepatitis. In fact, it's the only thing actually which improves the survival. Now there is coming the role of steroids, but nutrition is the main thing which improves the prognosis in patient with alcoholic hepatitis.
Yes, sir.
So what do you do for nutrition?
So, sir, the recommendation is for calorie and protein intake. So there should be a high protein diet. So 1.5 to 2 gram per kg per day, sir. And total calorie should be total calorie intake should be around 25 to 30 kilocalorie per kg per day.
But this guy is in the ICU. I don't think he's going to be able to eat that much. Or do you give parenteral? How do you give him nutrition?
So we can feed him via nasogastric tube or along.
Right. So basically, unless there is a strong contraindication for using the enteral routes, for example, somebody is in ILS, otherwise enteral route has to be used and has to be used early. So if the bowel sounds are present and there's no contraindication to enteral feeding otherwise, then put in nasogastric or nasojejunal tube as the case may be, because if the patient is vomiting a lot, you may have to just put in nasojejunal. But otherwise, just a simple nasogastric tube.
So, Pritush, how will you choose between the nasogastric and the nasojejunal tube in this patient?
Dr. Vivek, we also have to rush for the next case.
Yeah.
Sir, since this patient has history of altered sensorium,
Yes.
nasogastric tube has a slightly higher risk of aspiration, so
Very
what
good.
is a nasovaginal tube?
Yeah.
All right.
Yeah.
I think we'll stop the discussion here so that we have good time for the next one. And thank you very much
Thank you, sir.
for the audience and Dr. Singla and Pratyush for this interesting
Thank you.
discussion.
So the coming up next is a very interesting topic. We all know that prevalence of obesity has increased and the associated complication, diabetes, OSA, and various malignancy has increased. Surgery has been the traditional gold standard for the management of obesity, and now we have very good new tools, being it the medical management or the endoscopic management. So we have Dr. Arpit, who will be presenting on the very interesting aspect of the endoscopic management of obesity. Over to Dr. Arpit.
Thank you, sir. Good evening, faculty. So I will be talking about the endoscopic management of obesity. WHO has defined obesity as an abnormal or excessive fat accumulation that presents a significant health risk. Based on the 2016 estimates, there are 650 million obese adults worldwide, and it affects around 1/3 of the population in developed countries. 20% of the world's population has been estimated to be obese by the year 2030. So, per the BMI classification of WHO, anyone above a BMI of 25 is classified as overweight, and above 30 is classified as obese. While in the Asia Pacific region, the definitions have been overweight is above 23, and obese class 1 is above 25. 25 to 30 is obese class 1, 30 to 35 is 2, and class 3 is more than 30. So, endoscopic bariatric therapies are primarily recommended for patients who have failed non-surgical weight loss or weight maintenance with lifestyle intervention or lifestyle plus medications. They have medical conditions requiring weight loss for additional benefits. There is a step-up approach from lifestyle modifications, pharmacotherapy, bariatric endoscopy, and bariatric surgery. These are the modalities available. The advantages of endoscopic bariatric therapy: basically, it is safer, cost-effective, reversible, at least partially in some cases, repeatable, with minimal anatomic alterations, and increasing treatment options in patients who would not qualify for bariatric surgery. It also improves obesity-related comorbidities like diabetes, dyslipidemia, and non-alcoholic fatty liver. ASGE has given some recommendations for bariatric surgery. The inclusion criteria of patients should be who have failed weight loss or weight maintenance with lifestyle. The person performing the endoscopy should have a gastroenterology fellowship, ideally. Pre-operative screening should be done in all patients to assess the patient's nutritional status, eating patterns, registration with a dietitian. Routine laboratory tests should be done like CBC, lipids, kidney function, liver function, urine analysis, and nutritional screening. Post-operative maintenance has to be done post-procedure with reduced caloric intake, increased exercise, and to provide long-term follow-up care. The patient has to maintain a weight loss with and has to document the complications that have happened. For any procedure to be ASGE accredited, the efficacy of that procedure should be that there should be a 25% excess weight loss over a period of 12 months, and the complication rate should be less than 5%. The types of endoscopic bariatric therapies: we have a platter of therapies available. The space-occupying devices like intercastic balloons, transpyloric shuttles, the full sense hydrogels, which I will be discussing further. And there are other procedures in the stomach, which are primary obesity surgery, endoluminal pose, then endoscopic sleeve gastroplasty, transoral outlet reduction. In the small bowel, we have DJBS, that is endobarrier. Then gastroduodenal jejunal bypass, endobypass system, duodenal mucosal resurfacing, and other therapies like aspire assist and botulinum toxin. The mechanism of action at the molecular level: these endobariatric therapies act in several ways. First is they delay the gastric emptying and thus decrease the ghrelin, which decreases the appetite. They also increase secondary bile acid synthesis and accelerate the intestinal transit time. They cause increased small intestinal hormones like GLP-1, peptide YY, then improved metabolic profile, improved bile flow, restoration of the gut microbiome, and increased insulin sensitivity. The first therapy, the most commonly available, is the intercastic balloons. The first one is the Orbera. It is the most studied and widely used. So this is came in 1991 and had FDA approval in 2015. So it is a single spherical balloon which is delivered on a catheter and is filled with saline of 400 to 700 ml along with 2 to 10 ml of methylene blue. So methylene blue is put in this because in case the balloon ruptures, the methylene blue will get absorbed and it will change the urine color to green. So we can detect it early, the rupture of the balloon, and just remove it. The balloon has to be removed endoscopically for 6 months. After 6 months, the indication for this is adult patients with failed conservative weight reduction measures such as supervised diet, exercise, and those with a BMI of more than 30. Contraindications to an intragastric balloon are basically prior GI or bariatric surgery, any inflammatory disease like esophagitis, gastric ulcers, duodenal ulcers, or Crohn's disease, potential UGI bleeding conditions like vascular ectasias or varices, if there is a hiatus hernia of more than 5 centimeters or associated GERD, a structural abnormality in the esophagus like structure or diverticulum, achalasia, coagulopathy, liver insufficiency, gastric mass, alcohol, and others. So, coming to the data for it, AHG Bariatric Task Force reviewed 82 studies in 2015 and found the excess weight loss to be 25%. Excess weight loss is basically the patient's weight minus the index weight for the patient. That is the ideal body weight, and then the excess weight loss is calculated. So another study evaluated 100 cases and found that over a period of 2.5 years, only 25% of the patients managed to maintain that weight loss, while 75% regained it. Another case series of 143 patients found that there is a decreased incidence of metabolic syndrome, diabetes, as well as a sustainable effect even 1 year post removal of intergastric balloon on the diabetes and metabolism. Then a meta-analysis of 44 studies was done, which showed a pooled total body weight loss at 6 months was 13%. The most common adverse event associated with this is nausea, vomiting, and pain, particularly during the first 2 weeks. So this period is called the adaptation period. Also, there are serious events which are very rare, such as bowel obstruction, gastric, or esophageal perforation. Then another balloon that was introduced was reshaped tube, which were 2 silicone balloons connected with a single tube, and they were placed endoscopically in the stomach. However, this was withdrawn from the market in 2019 by the company. Another balloon that is the adjustable intergastric balloon was Bart's balloon. This balloon was endoscopically inserted and inflated using saline. The advantage for this balloon was that it could be adjusted repeatedly, the volume based on the patient's tolerability. If the patient tolerated well, the volume could be increased. If the patient had a lot of side effects, the volume could be reduced. So the excess body weight loss that was found with this was 26% at 6 months and 38% at 12 months. However, a very high volume, that is 39% of the patients had this balloon removed early due to catheter shear, a perforating gastric ulcer, deflation, gastritis, or malarious tears. In our trial at 7 US centers on patients with obesity, which was done for 32 weeks, the total body weight loss was 15% in adjustable intergastric balloons with lifestyle intervention, while 3% in the lifestyle. Early removal of the device due to intolerance was seen in 17% of the patients in this study. Another balloon, the heliosphere, is a gas-filled balloon. So basically the advantage of this balloon is that it has a better tolerability. It is significantly lighter, that is 30 grams, versus a fluid-filled balloon that is around 500 to 700 grams. But there is a high risk or rate of system failure with these balloons, that is with positioning, spontaneous deflation, absence of a marker such as methylene blue, and a large size of the balloon. It is not FDA approved yet, and a study that was done on 82 patients with a mean BMI of 39 kgs found the mean weight loss of 14.5 kgs. This Obalon balloon is a recently introduced balloon. However, it was FDA approved in 2016. It is a soluble, endoscopy-less intergastric balloon. In this, a thin-walled gas-filled gelatin capsule is which contains the deflated balloon is taken solid by the patient. Once the capsule is ingested, the catheter extends from the stomach to the outside to the esophagus and mouth. Then fluoroscopy is used to ensure that the catheter is prepared to be inflated via microcatheter, and gas goes into the balloon to a pressure of 13 kilopascals with a volume of 250 ml. So a maximum of 3 balloons are placed over a 12-week period, 1 each month, and they're removed after 6 months. They usually now these gelatin capsules are also disposable, which do not need removal. That is a new advantage. advantage. So pilot study on 17 subjects showed no significant side effects and then additionally weight loss was significant at weeks 4, 8 and 12. Another soluble balloon has come, that is the Lfts balloon, which has a higher volume, that is 550 ml fluid, and can be kept for 4 months. So for the Obalon balloon, a double-blinded RCT was done on 387 patients with a total weight loss of 7% versus 3.6% in the placebo arm, and non-serious adverse events in 91%. There was one bleeding ulcer and one balloon deflection. The advantage was that weight loss in this was maintained even at 48 weeks of 88.5%. Comparing all the balloons, we can see that with the Orbera balloon, the total weight loss is around 13.5 kgs percent, while the Sparts, Heliosphere, and all the other balloons have a range of 26 to 30%. Coming to the adverse events for these balloons, the V-shaped balloon has a high rate of vomiting, that was 86%. Orbera also has similar 86%. The Obalon balloon is advantageous in this case with a vomiting rate of less than 70%. Gastric ulcer were also very high, that was 35%, while Orbera and Obalon have very less incidence of gastric ulcers. So it was seen that air gas-filled balloons were better tolerated. However, they resulted in a lesser weight loss. Another type of shuttle, that is the transpylori shuttle, was introduced. It is a balloon basically placed at the transpylori position between the stomach and duodenum. Received FDA approval in 2019. The device is inserted with a smaller and a larger bulb in the duodenum and stomach, which works as a ball valve. So intermittent obstruction at the pylorus leads to delayed gastric emptying with larger periods of satiety. The trial for this was the Obesity 1 trial, which was a pilot study in 20 patients and showed an excess weight loss of 25% at 3 months and 40% at 6 months. But early device removal was seen in 2 patients only. Another device, that is the full sense device, is basically a modified fully covered gastroesophageal stent, which is placed with the cylindrical esophageal component and a gastric disc. This gastric disc applies pressure on the cardia and induces satiety. Aspiration therapy is by Aspire Assist, which is a PEG tube basically. So it removes part of an ingested meal through an external skin pore 20 to 30 minutes after consumption. It is placed exactly like a PEG tube. The external bumper that is placed, the patient returns after 1 to 2 weeks, and then this bumper is converted to a skin pore, which is used for aspirating the contents. It received FDA approval in 2016 for a BMI of more than 45. Initial studies have shown a 49% increase in the excess weight loss and can be kept for 1 year. The trial for this was the Pathway trial, which was a 52-week trial in which 207 participants participated and were assigned in a 2:1 ratio. They had an excess weight loss of around 10%, 9.8%. 58% versus 15% lost at least 25% of the excess body weight. So that's why it received FDA approval. And the most common adverse events were abdominal pain, discomfort, peristomal granulation tissue, and irritation. Now the endoscopic sleeve gastroplasty, which is coming up as the replacement for the endoscopic for the surgery. It is a transoral endoscopic gastric volume reduction technique. In this, a series of full thickness plication sutures are placed through the gastric wall, right from the prepyloric antrum to the gastroesophageal junction, which creates a restrictive sleeve, which we can see here, that a sleeve is created. This requires a double-channel therapeutic gastroscope and an endoscopic suturing device. It reduces the functional capacity of the stomach and increases the satiety. The indications are mainly BMI above 30 and those who could not maintain weight loss with lifestyle changes with or without medications. Those who are not suitable for bariatric surgery or those who are not willing for the surgery, failed treatment with gastric balloons, patients who want a more effective treatment option compared to gastric balloons, or those who regain weight even after gastric sleeve or gastric bypass. So, contraindications for ESG are prior gastric surgery, gastric ulceration, acute gastritis, anticoagulation, pregnancy, and psychiatric disorders. The PROMISE trial was its pilot trial in which 20 patients were taken up with an excess weight loss of 48% at 12 months and 35% of adverse events with none were serious. Patients also had clinically significant reduction in diabetes, hypertension, and metabolism. A very recent trial, that is the MERIT trial, came up in which 208 patients were taken at 9 US centers with an average BMI of 35.7. The excess weight loss was very good. That was 49.2% at 12 months with ESG, with a serious adverse event rate of 2%. Also, a retrospective analysis of 248 patients showed the total body weight loss of 15 kgs and 18.6 at 6 and 24 months. Out of which there were 5 procedure-related events, in which there were 2 perigastric inflammatory fluid collections. So one of these complications of ESG is perigastric inflammatory fluid collection, but it can be treated with antibiotics and percutaneous drainage. Then extragastric hemorrhage in 1 due to splenic laceration, pulmonary embolism, and pneumoperitoneum. A meta-analysis was done which compared laparoscopic sleeve gastrectomy versus endoscopic sleeve gastroplasty, in which there were 16 studies of 2,188 patients. The mean BMI was 34 versus 34, comparable. The excess weight loss was 80% in laparoscopic, while 62% in ESG. However, both were safe and there was no significant difference. So there was moderate superiority of laparoscopic sleeve gastrectomy versus endoscopic sleeve gastroplasty. I have some Indian data also. One was published from Asian Institute of Gastroenterology, Hyderabad, in which 26 patients were included who underwent ESG with a mean age of 41.5 years and a mean weight of 99.4 kgs. And they had significant improvement in alanine ALT, NAFLD fibrosis score, hepatic steatosis index, FIB4, APRI, also significant improvement in HbA1c, with a total weight loss of 18% at 12 months, with no major adverse events. Another Indian study done at Indore had 53 patients, in which mean BMI was 34. This showed that the total weight loss at 6 months was 14% and 19% at 12 months, with no serious adverse events. So even in the Indian setup, ESG is very effective and safe at promoting weight loss. Another therapy called the primary obesity surgery endoluminal, that is the post surgery, in which full thickness tissue anchor plications are placed in the gastric fundus and in parts of the distal body. So post 2 came as a modification to the primary post procedure, in which full thickness plications were placed only in the distal body and not in the fundus. So the outcomes of distal post were that total weight loss was around 15% with an excess weight loss of 38, and more than 10% of 10% people achieved more than 5% of the total weight loss. Another therapy called the transoral gastroplasty created a stapled sleeve along the lesser curvature. So the difference here was that it created a sleeve along the lesser curvature with a restricted outlet. But in this, the rate of staple line dehiscence was very high, with a multi-center study of 67 patients showing an excess weight loss of 29%. Another system called the Terrace was all these are not FDA approved right now. Transoral endoscopic restrictive implant system, which was a prosthetic diaphragm placed at the gastric cardia to create a small reservoir. There was pure durability and side effects, and it was discontinued. So comparing the restrictive endoscopic bariatric therapies, the transpyral shuttle has an excess weight loss of 30 to 50%. The Aspire Assist has a 49% weight loss. ESG has a total weight loss of 20%, while excess weight loss of around 60% in the meta-analysis. And the side effects with ESG and nausea, bleeding, abdominal infection, and perigastric collections, as I had mentioned. Then malabsorptive endoscopic procedures like the DJBS, that is the endo barrier, in which a Teflon sleeve is placed right from the duodenum and it bypasses the duodenum, proximal jejunum. Thus, the pancreatic biliary secretions that are secreted are mixed with food only later in the GI tract. A meta-analysis of 5 RCTs and 10 observational studies showed that the excess weight loss was 12.6% at 12 months, compared with diet modification, with mean difference in HbA1c and fasting plasma did not reach statistical significance. The endo trial showed that the efficacy endpoints were met with 60% patients. However, there was a 3.5% hepatic abscess rate. So this is a complication that is significant, that is 3.5% of liver abscesses. Another sleeve called the gastroduodenal bypass sleeve, in which a 120 centimeter sleeve is created right from the GE junction. Thus, it excludes the stomach, the duodenum, and the proximal jejunum. It bypasses all this. So, in a prospective single-sided trial, it was delivered in 22 out of 24 patients and was retrieved endoscopically from all 22. with an excess weight loss of 39% at 12 weeks and 54% at 12 weeks. A new technique called the duodenal mucosal resurfacing has come, in which specialized radiofrequency ablation technology is used to ablate the superficial duodenal mucosa after lifting it up with saline. So, in a study of 46 patients, 24 weeks post DMR, HbA1c had reduced, while weight showed only a modest improvement. So, it is a feasible, effective study for glycemic control, but not for weight loss currently. Comparing the malabsorptive endoscopic bariatric therapy studies, the endo barrier has an excess weight loss of 12.5%, endoluminal bypass of 54%, while duodenal mucosal resurfacing does not have a significant weight loss. But with the endo barrier, another side effect is pancreatitis that we can see. So, a proposed step-up therapeutic approach was given by Dr. Anna Hoff, in which it's a step-up approach starting from diet and exercise, followed by diet exercise with weight loss medications, then addition of an intercastic balloon. After that, we can add intercastic balloon with weight loss medications. Subsequently, we can come up with endoscopic sleeve gastroplasty, followed by ESG, weight loss medications, and all the therapies. Even if the patient does not have satisfactory weight loss with this, then we can offer bariatric surgery. And finally, revisional of the ESG, TOR, or APC, other modalities. So, post-procedurally, how do we have to maintain the nutrient therapy? So, day before the procedure, we keep the patient on liquid feeds for both intercastic balloon or ESG. After the procedure, patient can start sips of liquid once feels like taking for IGB and has to be kept nil per oral for 8 hours for ESG. First 2 days, restricted liquid feeds and nutritional supplements. Day 2 to 7, smooth liquids. Day 8 to 11, paste feeds. Followed by, from day 15 onwards, he has to be on a caloric restricted diet with 50 to 60 grams of protein and maximum 1000 to 1200 kilocalories of calories, 50% carbohydrates and 30% lipids. Also, nutritional supplementation has to be done in all patients who undergo ESG and if necessary after IG. Supplementation, proteins can be supplemented, should take 60 to 80 grams, so we can give whey protein, around 25 grams of protein. Vitamin B1, B12, folic acid should be replaced. Also, iron replacement, particularly in women of reproductive age group. Then vitamin D, calcium, and vitamin A, E, and K. Replacement has to be done adequately. Take home message: endoscopic bariatric therapies are effective therapies with a better safety profile compared to surgery, less invasive, reversible, and more cost effective. They result in a significant and durable weight loss with long-term improvement in obesity-related metabolic comorbidities like liver, hepatic steatosis, liver fibrosis, and CVD risk. But more studies are needed to assess the long-term complications and nutritional deficiencies are required. Thank you.
Thank you, Arpit, for the wonderful presentation. And regarding the balloon, you mentioned a balloon is a endoscopy-less balloon. I think to remove the balloon, we need one endoscopy. While putting the balloon, you may not require the endoscopy, but when you want to remove the balloon, that time we have to remove the balloon. I think ellipse is a endoscopy.
Yes, sir.
Yeah, so ellipse is the only balloon which is endoscopy-less as of today. So my first question is, right now we have 3 types of balloon in India. One is the Orbera, then next is the Spats balloon, and third is the ellipse. So in a particular individual, how should we choose the particular type of balloon?
Yes, sir. So if the patient has a good adaptation and tolerability, Orbera balloon has shown good results. So that can be given. However, if the patient is very apprehensive for endoscopy, then will have to offer him the ellipse or the oblong.
I think the one difference is adjustment. In the Spats balloon, it has a long catheter attached to it. Okay, so you can adjust the volume of Spats balloon. So sometimes the patient has a poor tolerance to the balloon, so you can reduce the volume of balloon. And if there is not a desirable weight loss, okay, then you can increase the volume of balloon also. So between Orbera and the Spats is adjustable, but that come at the cost. Due to catheter, sometimes there can be injury. Case reports of gastric perforation, okay, due to the pressure necrosis of stomach due to the catheter attached to the balloon.
Yes.
Yeah. And you mentioned one algorithm that we should start with the diet and exercise. I agree with that. Then you mentioned balloon, ESG, then surgery. So you want to say every patient who is a candidate for the surgery, we should offer balloon first? Is that the idea? Yeah.
Oh, sir. So the Hoff scale gave a gradual incremental approach, but I think in the young patients who are willing for surgery, because surgery has shown good results and they will be the results will be sustained over a long period of time. We can offer surgery initially as well, right? Is based on the patient's acceptance as well as the feasibility. If there are no contraindications for surgery,
I think we should also check for the BMI of the patient. If the BMI is very high, more than 40, surgery should be the upfront. On the other hand, we have many diabetic patients who are obese, BMI between 35 to 40. They are on insulin, they have joint pain. So there the desirable weight loss is around 10 to 20%. In those patients, we can give an option of balloon or the ESG. So it depends upon the BMI also. Sometimes we have a patient with a BMI of 35, but significant OSA. They have the sleep apnea. So in those patients, I think balloon or ESG can be an effective modality. So I think we should look for the baseline BMI in these
BMI
patients.
also, sir.
Yeah.
So what's the current cost in India, do you know, for the each of these balloons and also for the ESG? Vikas might be able to help us here. So
I think the cost of balloon, Orbera and the spats is nearly 1 lakh. And for the ellipse is not widely available. I think the cost is between 2 to 3 lakh. And the ESG, it depends on the number of suture you require each patient. The cost of one suture is 50,000. So and you will require anywhere between 4 to 6 sutures per patient. So the cost of equipment will be around 2.5 lakh. Along with that, you can add the hospital stay of the 2 days.
and also, if the patient has had a ESG and then it doesn't work as well, and you want to go ahead for bariatric surgery, does that create more problems for the surgeon?
No. I don't think if the patient has
Because they do a
undergone.
gastric bypass, I suppose. Then you go for gastric bypass, so it should not cause problems.
So I think there are studies which have shown that after the ESG, lap sleeve gastrectomy can be done. I think same way surgeon can do the mini gastric bypass also.
Bypass.
Yeah. So Pratyush, now a lot of I think we are entering a very exciting era now. In the recent time, there are 2 publications regarding the role of injectable therapy for the weight loss. I think one was with the semaglutide, which has shown a weight loss of 15% of total body weight. Okay. And another study, I think that was with the tirzepatide. Yeah, that has shown a weight loss of 20% weight loss. So right now, if we compare between the LSG and the ESG, we can say there is higher weight loss with the surgery. So do you think in the future, if you combine the 2 modality, injectable with the you can say balloon or ESG, we can have equal outcome as compared to surgery? What's your take on that?
Yes, sir. So if we combine injectable therapy plus ESG, we can have comparable or even better outcomes compared to surgery, because the trials with tirzepatide had just recently come, sir. In 2022, it was published, which has shown a total weight loss of around 20%. Which is very good, sir. So combination therapy can be used in the future.
So there may be additive effect of the endotherapy because you want to achieve a weight loss of 30%. With the surgery, I think there is a weight loss of 30% of total body weight. So you want to achieve that level. I think when we add endoscopic therapy with the medical therapy, and imagine we have oral tablets later on, so that can be a total game changer. So the endoscopist may have a very crucial role to play in the management of obesity in the near future. Yeah. Dr. Raj, what's your comment on that?
Yeah, right. No, I think that it's going to become increasingly the one thing that I think in India is the cost, which is a basic, differentiator, because bariatric surgery is available at a reasonable rate for 2.5 lakhs, 3 lakhs, and with endoscopic therapy also costing nearly that much with the endotherapy therapy, there is hesitation for patients to undergo that. So I think that barrier is slowly breaking down as we get more experience in terms of the endoscopic sleeve gastrectomy and other thing. And yes, injectable therapy, if it comes in, is going to suddenly replace a lot of these things if it gets proven that it's safe and long term. So
And
I think.
yeah. Yes, sir.
And since obesity is becoming an increasing problem worldwide, especially in India, given diabetes and other complications associated with it, I think obesity management is a major problem that we are going to face, and obviously solutions will have to be found. And new drugs, new devices have kept coming up and will keep coming up. And I think endoscopists will play increasing role in this whole journey. So it will take maybe 5 to 7 years, but I think we'll probably find a more optimal way of managing these patients.
And we should not forget that exercise and the diet, they should be the first line of treatment. I have
Always.
seen many patients who have lost 50 kg, 70 kg with the just diet and exercise.
Absolutely.
So that should be the first line, that should be offered first. If that fails, then comes the role of surgery. If the patient is not motivated, nothing is going to work.
I think it's worth spending that 5 minutes extra for patients to give them proper dietary and exercise advice, because we leave it to the dietitians at times and leave it to other people. That doesn't work. So it's when it comes from the doctor who's generally concerned about your weight, it definitely has more impact. And I have many patients where I, give them broad general advice, not diet plans, not chart plans, but basically say plant-based diet, calorie restriction, cut out sugars, cut out fats, everything. And it's very doable. So I call it my jungle diet that God dropped you in the